I thought it would be kind of a good idea and certainly encourage participation, whether by hands, microphone, et cetera, of just how we can kind of interplay this and how genetic testing can be used more in real time. So with that, and maybe, should I just?
I can, who's going to ask a question? I have one for Brian. You don't run away. So I sort of got the feeling that we're back to the future. When I put this talk together last night about the evolution, everything in the 90s was about SNPs. They were looking for individual SNPs, and they sort of went away, and now you're bringing back with the profiling SNPs again. What's the difference between then and now when it comes to SNP identification and prostate cancer?
Right, so understanding again what SNPs are, these are the little variations throughout everyone's DNA, and it used to be a huge deal to actually identify these SNPs that were specifically associated with prostate cancer. So there are many different ways that we were going about these, but certainly when GWAS, or genome-wide association studies, came into play, it became a little bit easier. But the cost of doing these studies was also exorbitant, right? So to find one single SNP associated with prostate cancer, it was a major overhaul, because you had to basically genotype, again, the different platforms that were available, thousands and thousands of men, and you had to genotype thousands and thousands of controls without prostate cancer, and you would compare them and ultimately come up with a signal, and the first signal was on a chromosome 8q24. We were very, very excited. And then ultimately we were able to slowly add SNPs and kind of create these scores. But it was still very difficult, and we weren't really getting the full picture of what was actually happening. Now the cost of genotyping is very inexpensive, and you can get a entire genotype analysis for really $60 or less, depending on the company, and so it's very, very inexpensive to do. We have large data sets now that we've certainly discovered and validated. We've been able to account for various ancestries, so Black populations, Caucasian populations, Asian populations, and we can create kind of multi-ethnic polygenic risk scores. And so with that, whether we're talking about prostate cancer or cardiovascular disease or bone health, we're really able to use those to really stratify risk. Right, so in terms of, as an example, in cardiology, these polygenic risk scores, which again are accumulation of the different SNPs and their effects, are used in cardiology to help not only identify risk, but decide who would benefit from statins and cholesterol and kind of more intensive treatment and workup. So that same concept is really kind of coming around again. It's a lot easier because we have so much data, and these are not rare. Every man will have a certain number of them. And we've really seen a lot of utility, certainly in the trials that we have performed, et cetera, with this. So I think we're going to start seeing a whole lot more of this.
And I think you made a comment, this is so broad-based, goes to BPH, right? It goes to diabetes, it goes to cardiovascular. So this whole area of SNPs and things like this is really taking off way outside of our world of prostate cancer.
Good morning, Lenny.
Good morning, Dr. Abala. Glad to see you awake so early.
Barely. Maybe can you address the education for younger people? You guys are kind of a rarity. There aren't a lot of people in this space, and when I trained, obviously none of this was known. But what are we doing educationally to educate younger people? I mean, I don't know of any. Maybe do you have any courses at Jefferson for the residents, or how do they pick up this? And Brian, you kind of learned everything on the fly, I think. Am I correct? I mean,
or through a PhD, but
yeah, exactly. But I mean, what are we doing to educate? I mean, it seems like people are, learning as we go. But is there a better way to?
So he has a PhD, and I stayed at a Holiday Inn Express in 2014. So the AUA, we do a course now at the AUA. With the SUO talking about advanced prostate cancer, and embedded in there is a lot about genetic testing. We used to do, with Brian Morgan and a couple of other people, we used to do basically a hardcore genetic and genomic testing course at the AUA. We did it for about 5 years, and they wanted us to sort of cycle out of it, but that's kind of on the AUA side. There are courses that you can take online. Not Stanford, but somebody in California actually has an online course that you can do to sort of get a mini exposure to genetic counseling, which is meant for clinicians. But I think, Dave, what's really happening is that molecular biology is now embedded in what the residents do every day. I mean, once we get away from the robot jockeys of the world, no offense, David, but when we back away from the robots, if you really talk to them, looking at what's going on in bladder cancer, this is this whole bucket of precision medicine. So I think we have a lot more grand rounds on that right now. Again, I think the AUA does do some things, and there are online courses, but I think, Dave, as opposed to when we trained, these were all foreign concepts. I really do believe that they're becoming into AUA updates and things like that. But I think you have a valid point. As urologists in particular, medical oncologists do genetic testing. I mean, remember, they're 10 years ahead of us with breast cancer, so the medical oncologists all do a certain level of, genetic counseling in their training, but we're needing to bring our residents up to speed, and I think we're doing okay. Brian, you want?
Yeah, I mean, the other, I think, take-home point of all of this is that if you get into the real details, it can seem overwhelming. But at the end of the day, we are all comfortable with the concept of family history, right? Is to say, hey, you have a family history of prostate cancer, and I'm gonna make decisions based on that, based on screening and potential outcomes, et cetera. The genetic testing is really no different. It's just more quantified, right? So if you have a certain mutation, it says, hey, I can actually tell you what that risk is in a little bit more of a precise way. So when you start thinking about that, and you're saying, hey, all of this information is just telling me risk and prognosis, right, is to say that, yes, you may have risk, or you may have a better outcome with a certain drug or with certain treatments. That simple message is really what I always tell people to take home. Don't get so overwhelmed with, oh, is this a BRCA2? Is this ATM? Because you don't really have to know necessarily the genes. And what I'm working with a lot of the companies right now is simplify your reports, make them user-friendly for the urologist. Because again, when you start overwhelming that data on those reports, and you look at a foundation as an example, which has every gene known to, it's overwhelming. So just piece out what is relevant in our wheelhouse.
And I do think they're good for the patients too. The new simplified reports are easy for urology and the patients as well. But we're in this phase of precision medicine now. I mean, there's no question about it, and I think prostate cancer is really, in our urologic world, is really at the lead of that. Bladder cancer is now catching up with us with precision treatments for intravesical therapy and systemic therapy or things like that. So this is, the future of medicine, all these things that we're talking about. The details can be overwhelming, but I got news for you. I'm sure the kids in college now are probably learning about this. When you were learning about fruit flies and which fruit flies had the red eyes and the white eyes, right? That's what we were doing, and the Mendelian inheritance. I think there's so far. I'm sure PETA doesn't allow fruit fly research anymore, so I don't know if they actually do that, or if they crossbreed the fruit flies, but
Any other questions? Otherwise, we can go through an example here. Do we have a controller? Otherwise, I'll control from here. So just kind of how we can use this in real time is that this is an actual patient that I've seen in clinic. Again, we have a screening clinic, but this could be any clinic, and it's a 48-year-old Ashkenazi male who came in, and that's really his family history, right? He had a family history of prostate cancer, earlier diagnosis before age 55, still alive today, mother with early onset breast cancer, maternal aunt died of colorectal cancer, and his maternal grandmother died of pancreatic cancer. Again, getting what we call like the HBOC, all of those kind of cancers that we're familiar with here.
extending and asking about their family history. Otherwise, kind of healthy guy. And so, Lenny, I'll ask you: is that should this patient he wants to know, is he at increased risk of prostate cancer? And currently, based on this information, what would you actually quote his risk?
So, I mean, clearly the Ashkenazi population is amplified when it comes to risk of hereditary breast, ovarian, prostate, pancreatic cancer. The thing that we didn't really talk about at this meeting was something called GINA, which is the Genomic Information Non-Disclosure Act from the government. You have to be real careful. This gentleman's 48 years of age. The minute you tag him with a potential mutated BRCA2, BRCA1, whatever it might be, he can have challenges in getting long-term disability, long-term care insurance. GINA protects individuals from employment or getting health care. So you have to be careful, and this is why I throw this all over to the genetic counselors, because I'm scared that if I diagnose someone with a mutated gene and 5 years from now they can't get long-term care insurance or disability, I would feel bad. So I think this man needs a counseling. I think an alternative might just be put him on a little bit of an accelerated screening pathway before. I mean, I don't know if you would get him tested.
So I would, but I always tell patients that because most of the life insurance and disability insurance companies don't ask specifically about a genetic mutation. What they do ask is his family history. And so in a horrible way, I actually counsel patients to say, if you're reapplying for life insurance, either think this, but be careful about what your family history you're actually disclosing, because just based on this family history, his rates in the long term will be will be higher. So it is one of those where, that's the evil of, if you will, of our society based on that. But from a medical standpoint, again, I think it's important to know this information. There are avenues to get this information that don't have to be actually reported in your medical records. So that's the kind of conversation that I have. And I explain exactly that GINA.
So you do all this counseling yourself? You don't kick it over to a genetic counselor, you do it yourself?
The original discussion I always have with the patient myself. For me, if we see positive results, I then get them over to genetic counseling for further discussion of screening and other risks.
I guess I'm scarred from being in Philadelphia with so many lawyers running around that I would be scared to have that make the initial diagnosis in a 48-year-old. I mean, if he was 72 years old, I'd be less concerned.
But you have a lot more ability to help this guy than the 72-year-old in terms of that. So I would, and again, it comes to the point too, is that if we follow the AUA guidelines, he's 48 years old. Should we offer him prostate cancer testing as a baseline? Again, going back to some of the discussion we had yesterday.
So you would recommend this? You wouldn't just say, you're at increased risk because of the family history. Why don't we get a baseline PSA now and follow you? You would go right to getting germline testing.
I would do both. I would
the screening, but you would do the germline testing and screening. You wouldn't just do the screening alone.
Correct. Because his father was 54, so again, there's not a discrete recommendation wherever you look, but my general rule of thumb is to say, hey, if the youngest relative was 54, if we're going to get a baseline, do it at least 10 years ahead of time. But again, that's where some of that genetics can help us say, do we actually need to do this or not? And so he does get the genetic results. He does germline testing. He ends up having an ATM pathogenic mutation, as well as an APC-VUS. So again, goes back to that conversation we were just having. There's a lot of letters here. This seems kind of confusing. What does that mean to you?
So that's basically one of the classic, when you look through our classic prostate cancer, BRCA1, BRCA2, ATM in check, so it's in that pathway of increasing his risk for prostate cancer. But the bigger issue, it increases his risk for aggressive, life-threatening, metastatic prostate cancer. The VUS is, again, my fallback on the genetic counselors, because I think once a VUS gets identified, although in this guy it might not matter because he already has one pathogenic, but if it was just a VUS, you're obligated as the provider to follow the gene bank and make sure this VUS does not get converted to a known pathologic, mutation.
And so in that way, so VUS are variants of unknown significance. They're kind of like blah. 90% of them end up being recategorized over time as benign. So most of them are really not relevant, but it is one of those where, yes, most of the time you don't have to personally follow this. You're gonna get updates from the genetic testing company and saying, hey, we've just recategorized this, and so just you can let the patient know to breathe now. But again, most of those are benign, but we also, at this point, once you see a pathogenic mutation, even if it was just a VUS, get them over to genetic counseling to talk about that risk. But that patient's still now looking at me and saying, well, what are the next steps here? And again, based on that, if you look at the data, it's about a 3.3-fold higher risk of prostate cancer and a equal risk of aggressive disease. So we offer him and we get a PSA. His first PSA at age 48 is 2.8. We okay with that?
Yeah, so I mean, I think that's a little bit of a red flag right out of the gate, and then looking at his father being diagnosed at age 54. So, again, based on the data that we know, it should be repeated once before you act on it. But I think that this man deserves an MRI, and probably that's what I would do.
So I love that you said that. That was the trick question here. So repeat, right? That's always the urology take-home point. Yeah. Repeat was 3.2, and his prostate health index, which is what we use, was 48, saying that there was about a 1 in 3 or higher chance of having prostate cancer.
So I'm sorry, Brian, but you do what school are you? Are you MRI biopsy or MRI biomarker biopsy? Where do you go?
Biomarker, MRI.
Or biomarker first?
Correct. To stratify if we should proceed with the MRI, because in prediction of having a positive MRI, the biomarker is way higher than the PSA.
So the question I have is to kind of get back to Lenny's concerns about opening Pandora's box with the genetic screening, right? So you have a guy who has very high family, very high risk from the family history out of the box. He's 48. Why not just say, you're at high risk, I'm going to get a PSA. Okay, and then his PSA comes back at 2.8, which if his prostate is small, then you're going to get an MRI, and then you're going to go on to biopsy. Then you say, oh, you have prostate cancer, and then we can do all this genetic stuff.
No, I didn't say, he should be screened. There's no question. If you look at all the guidelines, Ashkenazi Jewish population is listed as high, like African Americans start early, family history start early, so he would hit the box for getting the PSA, under the age of 50. Absolutely.
What I'm saying is, get the PSA, get the MRI, then worry about the genetic stuff, so you don't sort of impact on his perhaps insurance issues down the line should his biopsy prove negative. And you've opened up this Pandora's box of these genetic things, which who knows what that all means. That's my question.
I would follow through if it looks like he's going to end up with a prostatectomy. Then you sort of follow through with what further testing do you want to do. You probably want to do somatic and germline in this guy, but we'll see what Brian ended up doing with him.
I just want to make a point about the VUSs. I've tried to refer patients with VUSs to genetic counselors. They look at why I'm referring them, and they say, we're too busy to see these patients. Reassure your patient, and we'll, keep an eye on them. And so I think that's an important point that I've said to patients. Look, the genetic counselors don't even think you need to be seen for this. I sort of flip it around. But to our point from yesterday about how the genetics counseling world is just so overwhelmed, they're not even seeing these patients where I've worked. So a quick point about that.
Yeah. Well, they also have, the other thing we have is a genetic tumor board at our place. We actually have a master's program in genetic, again, so each of us, Brian's world and my world are each a little bit different than your world is, but at our place we actually have a genetic tumor board every week. But again, we do have a master's program in genetic counseling at Jefferson, so that kind of enhances, elevates the discussions.
So ultimately, and it looks like we're kind of running short of time, but he ended up having grade group 1 cancer in mostly the region of interest and other places. And again, this is an ATM carrier and it's seemingly low risk disease. do you do other genomic testing? Do you talk about treatment? What is your discussion at this point? And certainly drawing on the data, suggesting that outcomes may be, there's just a significantly higher risk of having grade group 3 or higher on surveillance over time. So I think we'll probably end there, but if just, I guess, comment on management strategy based on that.
Well, you're going to get, you're going to get, I think, radical prostatectomy on this guy, probably at his, even though it's grade group 1. I think it's a fait accompli. I don't speak French, but I think, his pathway is going to be not good. The question is, when do you get the actual germline and somatic testing? Is the multidisciplinary discussion that you would have with everybody. So what would you do? Do you use Artera, or are you using all the
So for this, I mean, we as on research protocol more than anything else still do genomic testing for all of our active surveillance patients, but again, that's very data driven, et cetera, and it's just a piece of the pie. Again, saying, hey, how many factors promote saying, hey, this guy will be successful in active surveillance, and how many of those, whether it's genomic tests, PSA, pathology, et cetera, are supporting, hey, he's not the best candidate. So that's really, again, it's not inappropriate to do, but again, a lot of our motivation there is just gathering that overall data. But ultimately, to spoil the story here, he did undergo a prostatectomy and had grade group 2, again, organ confined. But in a 48-year-old, I would say that was a successful story, just because, again, the natural history of this is specifically being an ATM carrier was not going to be a pretty outcome for him.